Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. And you know, we've had a number of conversations because you've asked questions about stroke and neurologic issues. So, what better than to have experts to answer your questions? So let me first introduce Dr. Ariol Labrada, who is a vascular neurologist, and they're involved in interventional neurology. Welcome, Dr. Labrada.
Thank you for having me.
Thank you for being here. And a very famous person, because he's been all over the news media, on television, because of some of the issues that he'll talk about. Dr. Kaushal, Dr. Ritesh Kaushal, and another interventional neurologist. And they both are involved at Palmetto General Hospital in Dade County with the Certified Stroke Center. So, welcome. Doctor.
Thank you for having me.
Good to have
Pleasure.
you. Dr. Labrada, what makes you an interventional neurologist?
So, let me go back and clarify a little more. I'm a vascular neurologist. It's the clinical part of the stroke. And we ran the program when Dr. Kaushal came, and he came with the expertise on the interventional part of the program. And that's been already almost 3 years, right?
3.5 years, yes.
But I'm the clinical part of the program. Kind of the first line doctors that get the stroke in the emergency department when they present with all the stroke-like symptoms.
Let's talk about strokes themselves.
Right.
And let's talk about the timeliness of what both of you do and the importance of what has happened at the institution where you present your services, which is Palmetto General, and because it's a certified stroke center. So tell us what is involved with that.
Right. Stroke, just to define stroke, stroke is an extremely complex problem. It involves essentially the management of stroke involves so many steps that have to be done in such a timely fashion that it becomes very critical to have a very compact and unified team that works very smoothly. And that's what happened when we started together at Palmetto General Hospital. We built a comprehensive stroke center, which actually is one of the only 4 certified Joint Commission comprehensive stroke centers in the whole state of Florida. So there are only 2 in South Florida, Palmetto General being one of them. And the whole management of stroke and why that is so critical is essentially, if one thing that we all can remember is that we lose about 2 million brain cells every minute in a stroke. So just a delay of care by half an hour, we've lost close to about 60 million brain cells. So that's the impact that timely management of stroke becomes so critical. And we're a comprehensive stroke center, so we've actually honed this whole system, and we've kind of improved work on the system and kind of almost have perfected it now to the point where before we joined in, just as an example, there's a certain medication that's given called TPA, which is one of the few medications which works in stroke, and that medication again has to be given as soon as possible. And before we started, our average time from the patient arriving to the emergency department to getting the medication, the time was 72 minutes. And now currently our time is 28 minutes. That's all because of Dr. Labrada, Dr. Mejia, and our whole team, their sheer hard work, that we've reduced that time from 72 minutes down to 28 minutes. And just to put that in perspective, the average of the whole country, and Florida including, is about 54 minutes. So we're still doing it almost twice as fast as the rest of the country or even Florida.
The general public doesn't recognize the immensity of the relationship and the importance of the relationship between the paramedic EMTs in these vehicles that come, usually they're fire department related vehicles,
right,
that come to the scene, put someone into their vehicle and communicate with your center. Let's take it from there.
Right. No, that's a very very important point, and it's also extremely timely because starting next week, in fact, starting February 1st, there's going to be a huge shift of the whole pre-hospital triaging system of stroke in Miami-Dade and in Broward. In fact, the whole Tri-County region. What traditionally was happening, if you can imagine, a patient or the family member calls 911. The paramedics get to the patient's house, they pick up the patient, they obviously stabilize the patient, make sure everything is okay, but they have to get the patient to the closest appropriate center. Once they get there, the ED physician evaluates the patient, then he calls, the vascular neurologist. The vascular neurologist, if that patient needs an intervention, would then call me, then I call the team in, and so on. So everything was a pretty linear process, one following the other and so on. And then in talks with EMS, and the fact that what we realize now is that EMS is extremely sophisticated, and these individuals are selfless individuals who really the main concern is the patient's health. So with some education, we actually now are at the level where EMS or the paramedics can almost to a certain degree replace the ER triage. So instead of the ER physician, the paramedics getting the patient to the ER and then the ER physician evaluating the patient, what we found was that if the paramedics can evaluate that patient in the patient's house and then call Dr. Labrada or call me directly from the patient's house, and then we all, and mainly this obviously works more in off hours, evenings, weekends, and so on, when we are not in the hospital. So if they call us from the patient's house, we all start driving in. So in fact, at the same time when EMS is bringing the patient to the hospital, we are half the way there, or even maybe there all the way. So that ends up saving us another about 20 to 25 minutes. And again, that 20 to 25 minutes translates to about 40 to 50 million brain cells that potentially would be saved. So in that, because EMS has now become so important and that recognition has become so strong that they can identify the strokes. They've been doing this day in, day out, and they actually many a times make more as a percentage a correct diagnosis than a lot of other times, even some other people or personnel in the ER. So that's why we think that this model actually would work really well. And this model is, we're starting next week itself.
Dr. Labrada, let's take it from there, because we did a show with EMS paramedics here, and one of the issues that they brought up was their following protocols and communicating with the vascular neurologist and the team at the stroke centers, because again, not every hospital can deal with it. So there's a certain protocol which they go through, and these individuals happen to be EMTs, paramedics that were dominantly in South Broward, Hollywood, Miramar, right, Pembroke Pines, etc. And so they were explaining how they are directed by someone like yourself most often, and which unit they go to. So let's take it from there. What happens?
Yeah, so as he was explaining, I think that this step that is coming up will shorten the time that the patient will, that we will have the patient in the right place to be managed. Some of these patients, when the paramedics are giving us a call and telling us that, hey, we have the patient here that is about 10 minutes ago became weak on one side or the other one, still talking, still able to communicate and follow commands. For the most part, we kind of have an idea what kind of stroke we were dealing with. So that kind of patient can be moved into a different route, that the patient that is became weak on one side, is not talking, is only looking at one side with the visual field, and right out of the spot we know that this patient will require a higher level of treatment once he gets into the emergency department, and then we have the chance to, as he's getting into the hospital, being able to communicate with Dr. Kaushal and he will have the team ready, for the intervention. Some of, not having that in place will add at least 15 30 up to 45 minutes by the time that not having the system in place will take us to be starting to think about the interventional part. So I think it's just an amazing idea that is going to be in place. And everything we do is just in favor of minimizing the time that we provide the patient with the right treatment and minimizing the cells that are dying every minute. And that's the whole purpose of having this system. And I think every day that we wake up and go to the hospital and we come up with better ideas, I think the patients are getting better treatment. And I can tell you, I have been in medicine field since 1988. And I remember those patients initially getting into the hospital. Yeah, they came with a stroke, given an aspirin. Let's see what complication we had to deal with, and at the end, just rehab. And since mid 1990s, I think it was 1994, 95, the idea of the new treatments came up to now, we are like 100 years ahead on the treatment of the stroke. But we need to put that in perspective, that knowing that everything starts by the patient and family recognizing the symptoms. Because what happened is, and we still have the culture of a patient became weak on one side, oh, let me wait and see if that goes away. And, we don't only do the acute part, but we do the teaching part. And I think, and all these patients, they get with the TIA, the simple symptoms that they goes away. We have the system already implemented in the hospital where patient goes out knowing exactly what the stroke means, what are the consequences, and knowing that not only they get sick, but the family will get sick too, because now they have to turn around and everyone has to get involved on a patient who is probably wheelchair bound or bed bound, and things that could be avoided if we take the action right at the time that the symptoms start.
So the key word here is timeliness.
Absolutely.
So therefore, I'm going to talk about now what's been seen on television, and we through the relationship and I give a lot of credit to the city of Hialeah and their fire chief, and them placing an opportunity in the hands of you primarily. And you tell the story. What's happened?
Well, again, we get back to the same thing where we've developed such good relationships with the paramedics that most of them, or a lot of them, at least in Hialeah, we personally know them. A lot of them have my cell phone numbers and so on. So there's always this thing where they, once in a while they'd call me, even before we rolled out this formal protocol, which is going to start next week. But they would call before and they would say that, doc, this guy is having a bad stroke. You want to come in? So I was like, all right, yeah, I'll be there. And so they'd drive and they'd almost certainly be there before me. So then they had a standing joke, the doc is a slow driver. And I was like, no, I'm not a slow driver, but I don't have your lights. So then they were like, all right, so why didn't you get them? And so that's where this whole idea came of getting the lights in emergency situations. And unfortunately, we're all pretty familiar with the South Florida traffic patterns, which can change my commute from my house to the hospital is a 16-minute commute. And that can easily stretch to a 45-minute commute if I'm hitting office traffic or because of construction on 75. And so that's where this whole idea came, where Chief Anchia was extremely supportive of it. And they looked into the statutes for the state, and they said it was absolutely possible. And so then they installed emergency lights in my car. I've used it about 8 times so far. It's been about 3 months, about 4 months now since I've had the lights, and I've used it about 8 times so far. And really speaking, each time it saved me about maybe close to about half an hour.
Well, but the application of saving that time saves the patient and the quality of life that patient, if survives, will have, correct?
Very much so. Again, it comes back to that same thing of 2 million brain cells lost in a minute. And so every minute counts. I mean, we're looking at, just to be even, even the smallest things, we're looking at just the movement of the stretcher, the wheels on the stretcher, how fast can they move. So we're looking at all those tiny, tiny things, and here we had a huge area which potentially we could have saved so many more minutes. So it was almost a no-brainer to get that thing done. And just like it's a no-brainer now to have the paramedics triage the stroke from the patient's house and just call us directly, and in that sense not wait to take the patient to the ED. So all these things, I think, eventually, of course we all realize that it's not one aspect which is going to make the complete difference. It's all these things put together, and each one of these matter and each one of them count.
Well, and again, just to give you, it's the paradigm for that was set many years ago, and I give credit to a lot of different venues, but Johns Hopkins was very proactive in creating, with the American College of Surgeons, the protocols for trauma.
Right.
And it's the so-called golden hour. In other words, if the patient isn't taken from the scene of an automobile crash or an airplane crash or a drowning or whatever, and is placed into this, not just the emergency room, but a certified trauma center, within at that golden hour, the chances of survival are minimalized. Let's get to this issue of now the patient is handed over to you, and it's that communication again with the very highly skilled and trained paramedics and EMTs. I would assume that you start to, there's a FAST parameter or something?
Yeah. So yeah, they came out with the FAST kind of scale of parameters that were is being educated, and this is more for the population, and usually even for the ENTs that knowing what FAST means, and it's a way to evaluate the patient in a quick mode, knowing the face, arm, speech, and the time that the symptoms started. So it will be easy to have the patient in front and look at the face. If there is any deviation of the face, ask them to raise the arms. You may notice that one arm is getting, it's not being able to move. The speech, simple questions, and the patient sometimes can't say, but you can see that slurriness of the speech that is coming out. And then the other thing is when that started. So that will give you an idea that most likely we're dealing with a stroke, and knowing the time that is being elicited since the symptoms started, what will be the next step to proceed with this scenario. And for us in the emergency department, it gets a little more into what we do on every day. There's some other scales that are being created to evaluate the intensity, the extension of the stroke, and to be able to proceed with the treatments of what we do. Dr. Kaushal was mentioned before, the use of the IV TPA, which is a potent anticoagulant that is being used to, in certain mode, destroy the clots that are being traveling to the brain and causing the strokes. And that's mainly at the level of the ER, done by us or by the emergency department physicians. That's when we are able to really know the exact magnitude of the stroke and what will be the right treatment for this type of patients.
Dr. Kaushal, again, getting back to the relationship between the EMTs and both of you. Obviously, Dr. Labrada and his colleagues will assess the need for you to be involved in an intervention.
Right.
So tell us now what that intervention is.
Right. So just like Dr. Labrada was saying, about 20 years ago, we had nothing for stroke. Then came IV TPA, which was the first-line treatment. Very strong blood thinner, tries to break the clot up. Unfortunately, most of the strokes, and surprisingly in South Florida, a much higher percentage of strokes are what we call large vessel occlusions. So essentially, if you can imagine the stroke or the whole vasculature of the brain to be like a tree, so you have the trunk of the tree, and then you have numerous branches, the first branches and the smaller ones and so on. Out here, most strokes actually happen either in the trunk or the first main branch. So essentially, everything beyond that, nothing is getting any blood. Now, the size of the clot usually is much bigger, and so for the drug to work on that, unfortunately, it's not always effective. In fact, what we've seen in South Florida is these kind of occlusions, IV TPA by itself works only in about 25% of the cases. So majority of cases, or 3 out of every 4 cases, IV TPA alone is not going to be sufficient. So that's when, just in the last, in fact, 3 years or 4 years, 2012 was when this new device called the Solitaire, it's a stent retriever essentially, which basically got approved by FDA. And since then, we've seen a huge and dramatic shift in stroke care. What we do is, very simply is, we go in from one of the blood vessels, usually in the leg, and with a small catheter go all the way, just like what we do for the heart, the same kind of a catheterization. But here we bypass the heart, we go up to the neck, then we go up into the head, find where the clot is, we deploy the device, or we aspirate, and then we just take that whole clot out. And that usually, on an average now with this newer technology, it's taking us only about 15 to 20 minutes really. I mean, of course, each case varies, but on an average, maybe about 20 minutes or so to get the clot out of the head. So, and then we immediately see the blood flow is completely restored, and the outcomes now have shown a huge amount of an impact. What IV TPA alone, like I was saying, was doing it in only about 25% of cases. Here we see up to 60, 70% of cases where we see significant benefit of this process.
That's wonderful. You know, many of our viewers are people that are retirees here, and we got a lot of moms that listen to us, and we know the audience. But you know, South Florida, like you say, South Florida, you find different situations
Absolutely.
medically, and that's because we have what I would call the medical survivors, people who living into their 70s, 80s, 90s, and I always beg our viewers to please take good care of yourself. Please see your physician once a year. See them, because you never know what happens tomorrow until you know what your physician is to know today.
Absolutely.
So one of the things I want to ask you, because we're down to the last 4 minutes of the show, as part of a normal and natural, I guess you could say, checkup environment, where does this new sonography technology come in?
It's a good screening test for sure. I mean, I don't know whether it really, whether it needs to be done on everyone. I mean, of course, I would say anyone who is symptomatic definitely should get that. At the same time, so far, we do not consider that to be a screening test for everyone. That being said, what we've seen is the carotid, or what you're also talking about, the large vessel occlusions, they end up causing the most significant damage as well. So absolutely, I would say that if there are any symptoms, please, no one should really be waiting or be thinking about that. And that's where the first aspect of stroke, which Dr. Labrada was also talking about, becomes extremely imperative, that the public education component of it. We've had, unfortunately, enough patients who would wake up paralyzed on the right side of the body, and they would be, oh, maybe I just slept wrong. Let me just shrug it off, wait another couple of hours, and then still see that they're paralyzed, and then end up calling 911. And so you already lost 2 hours in that whole transit period, and you might have had the stroke much earlier on when you were asleep. Mm-hmm. So we that aspect, which is the first aspect of patient education, is extremely critical. And really speaking, this is one of the perfect avenues for that education, and that's why really we'd want to thank you for giving us this opportunity.
Wow.
But I think that is the most important part, that education of the community is extremely important in that.
We're down to the last 2 minutes of the show. Go ahead, Dr.
Yeah,
Labrada.
I just want to add, because you mentioned the preventive part of medicine and going to doctors every year. Some other conditions will require you to visit the doctor more often. But I think getting on the hand of the doctors, it will also have some contribution on being able to find risk factors. Like, when you go to the doctor, things that the doctor do will put your stethoscope on your chest, in your heart. They're going to auscultate your carotids, and And sometimes they're asymptomatic, and just the fact that you put your stethoscope, you can hear a noise that will may make you think that this is some degree of stenosis, and sonography will be the second step on that to be able to find, and I think that would be one of the use of the sonography that you were mentioned before, Doctor.
Well, thank you. We're down to the last minute of the show, so I really, again, a lot of the people, and I don't care whether they're young, old, or whatever, everybody wants to have a quality of life feature. And as both of you have stated in your comments, I said a minimum of once a year. So, but everyone should visit their primary care physician. Let me thank you on behalf of the entire South Florida community for your advocacy, not just your service at Palmetto General and what you do as physicians, but your advocacy in the whole field of stroke awareness, stroke therapy, etc. So I want to thank both of you, Dr. Labrada, vascular neurologist, and you, Dr. Kaushal, an interventional neurologist. Thank you both for doing what you do. You do it not only from here, but you also do it from here. I see in your eyes. So these folks out here recognize it. You'd be surprised how they see that coming through the television camera. So thank you both very much for being here.
Thank you.
We try to answer some questions because we've had a lot of questions about stroke, and hopefully this will entice you to communicate with your primary care physician. Many of you will have no problems at all, but the bottom line is, why not give your primary care physician the opportunity to ask you a few questions? And then it makes it a lot easier for Dr. Kaushal and Dr. Labrada to do what they do best, and that's to save the quality of life and to save life. So thank you once again for showing up and tuning in to this show. This show is called Dateline Health. We come to you from Nova Southeastern University. And I want to say that until next time, this is Fred Lippman saying, see ya.